Hi, this is Joe, and this is the long-awaited narrated PowerPoint that goes with Module 3. You're supposed to read this or look at this on Labor Day. I apologize because I would have given you Labor Day off if I had made out the recipe for the course, but I did not, so alas. Now, I have to tell you, the PowerPoint that was originally from Pearson was about 40 slides, and it was dry as you could possibly think of because all it did was regurgitate the text. Trying to put myself in the vision of being the person reading the textbook on those 10 pages, and that caused me many sleepless nights while I was trying to figure out what to say to you and given your stage of development as a new nursing student. And so I shortened it up considerably, and we do have to talk philosophy, but here we go. Exemplar 3B is the one on end of life care. It's about 10 pages long. Lots of statistics, lots of scientific stuff in there. Kind of misses the point, actually. The way it's written is if you're already an experienced nurse and you know all this stuff, then it explains it right there. It's all right there as a resource for you to have. But if you're a new nurse, it's like, what the heck are they talking about? We do have learning objectives. These are straight out of the book, but I have to tell you, the book also talks about first, differentiate considerations for care of children and adolescents who are at the end of life. Now, I put that in smaller font size because I'm de-emphasizing that. You don't have to read all about pediatric cancer. If you're new at this, just the thought of having a child with pediatric cancer strikes fear into your heart. And then also there's another section there in the book that says, apply the nursing process in providing culturally competent care to an individual at the end of life. Now, that is critically important, but we're going to spend about 6 weeks going over nursing process in excruciating detail, but we haven't done that yet. So I eliminated about 10 slides that were doing that. That doesn't mean we don't do the nursing process, but that just means we're not quite ready given what we've got. So now here's the challenge you all are going to have, which is you haven't actually met a patient yet. And for all these exemplars, I sort of said, oh, gee, they're kind of in a case study format. Well, this one really isn't, unfortunately. Some of them are. But I'm going to close your eyes, or maybe look at the slide. We'll go over Mrs. Mildred Smith, 93-year-old widow, nursing home, has hearing problems and arthritis. If you were to researching a new patient and you looked in their electronic health record, one of the things that would happen would be you would be getting the list of all prior medical problems that this person ever had, all prior surgeries, all prior medications. And sometimes if you look at the list from an end-of-life perspective, you wonder how she survived. And you say, oh my God, this person is ready to die at any moment. My dad happens to be 93 years old. He told me not too long ago, when I go to the doctor, I always start off by reminding him, no matter what you tell me, I can't die young. But the thing here is, don't expect, if you're a nursing student, you're going to make a common beginner mistake, which is you read all this, and then you think, oh my God, in order to be adequately prepared to take care of this person, there's so much to need to know. I need to know about breast cancer. I need to know about hysterectomy, skin cancer, dentures, glasses, hard of hearing. What are the pills she's on? And then all about hospice care. So it's like, if you are reading up, even when you're reading up on a case and they give you all this stuff, General advice is don't go having a heart attack just because there's a lot of medical things with your patients. So at the bottom it says, when you close your eyes to visualize this person, what and who do you see? Oh, yeah. So now, in other words, no peeking. I'm not going to tell you yet. Don't rush through this slide. Take 30 seconds to conjure up a vision. You're standing in the door, or you're standing at a respectful distance where she doesn't know you're looking, and you're kind of doing the door survey to see what they're going on. What is it that you visualize, given the history that you just heard about? About this person. I'm about to click the button and you're going to see what she looks like. You may want to be sitting down. All right, this is Mrs. Mildred Smith. I like to think that this was not what you were visualizing, or if you visualize somebody else, a sick person in the bed, all this other kind of stuff, that would have been wrong. Now, the reason I actually give this scenario is because way back, many years ago, I assigned a student to a patient who had a very similar history of this. When you looked at it, you read the history and physical, it was a wonder that the lady was still alive. Well, the student who lacked a lot of experience and background read up on it, and she basically became so anxious that she called in sick on the first day of clinical. And I'm like wondering, where the heck did Karen go all day? She just, left a message saying she wasn't coming in. Well, I had to meet with her, and basically she just said, well, I kept reading the chart and I was looking at that and I didn't know what to study and what to do and all this kind of stuff. And it was just so overwhelming for me. Well, guess what? The lady did have an incredibly long history of terrible things that she'd survived. And I said, well, gee, if you had only come in, you'd have seen a little old lady in a rocking chair who was lonely drinking tea. Now, one of the things here is we're loading you up on all kinds of things that are like, we read about it, the vocabulary is difficult, it's very scientific, it's overwhelming. We've taught you all kinds of things you need to look at, but the idea here is don't let that dismay you, and we're going to actually take the patient from where they're at. I pretty much can guarantee the people that you meet on your first clinical days will remind you of your grandmother. Doesn't she remind you of your grandmother? Maybe you didn't know her, but that's kind of the thing. These are, don't over medicalize it, etc. All right, so basically this is, I kind of went out of order on this. Here you are. You're new, you're young, you're enthusiastic, you look professional, you're ready to try it. What will you do, and what's going to happen? What's the biggest fear you have? It's like, oh my God, she's going to talk to me about some heavy story about the fact that she's dying and all her regrets and all this other stuff. Or maybe some other thing. Here's the thing to know. Don't let the cancer define who your patient is. Don't let the fact that they're on hospice or they have the hospice designation, don't let that get you to the thing of thinking, oh my God, this is too complicated for us to deal with. One of the issues when I'm thinking about, oh, what happens when we have a new person and then we have all this psychosocial stuff, one of the things is people that are saying, well, what if she does remind me of my grandmother, and then I'm worried about what we'll say, and I don't know what to say if the person looks at me and says, what do you think about my doctor? Or you think I'm dying, or blah, blah, blah. And the answer here is actually to be found in this chapter. Page 182, it talks about the awareness level of the patient that you have. And one phrase I love, which I hadn't really realized was an official phrase, was mutual pretense awareness. What you're going to actually find is, in many cases, even if the person's been officially told that they're dying and has officially done all the legal steps to prepare for how they want it to be handled and all that other stuff, and even if the family knows, one of the things you'll notice is the family walks in and the first thing they say is, "You should have seen the traffic on I-4 this morning," or about how the dog is doing, or something like that. And there is a subconscious process by which the patient will look at you and decide whether or not, based on your body language or cues that you give them, whether or not they want to get into it. And I tell you what, I mean, one of the things is, even if the person is at end of life, a lot of times, they want to talk about something else. They're bored. So you don't have to worry about that so much. I mean, I have to admit, we're telling you we have to have focused communication. We have to have intentional communication. But one of the things that will happen is you can talk with them socially. When we assess such a person, what happens? We focus on how they're getting through the day. You'll see the abbreviation here that says ADLs, which means activities of daily life. And you're going to hear that phrase over and over again throughout your nursing career. That's much better than walking in there thinking, "Oh my God, I have a cancer victim who's a hospice person. I have to get on the subject of very serious conversation from the get-go." And the answer is no, you don't. Okay, now in the actual textbook, it does actually define end of life, and it actually says all this stuff about dying in America. And the fact is, everybody wants to die at home, but a large percentage of people do go into a nursing home for the final years of their life. And we are in the state of Florida, and you have got your fellow citizens availing themselves of services with a social safety net, which is a great thing. We can help that person have dignity and a good life. And if you go back to that picture, Mrs. Smith, she's sitting on the veranda of the nursing home drinking tea, watching the bees. That's what we need to do. But anyway, moving right along, we are still going to be having compassion, whatever that may be, and we will be communicating with them and delivering skilled care. This one's straight out of the thing. It just basically says we've got a bunch of, here's what people mostly die of, which is amazing that the federal government keeps track of this, but we got the statistics and it tells us a lot of stuff. What you don't see in the top 10 is a lot of infectious diseases. 1, 2, 3, 4, 5, 6, 7. We don't, everything in the first 1, 2, 3, 4, 5, 6, 7. The first 7 things on the list are all chronic non-communicable diseases, which you almost could lump into old age. Old age itself is not on there. She's 93 years old. Maybe she's going to live to 102. We don't know what her genes are. But that's just kind of like who to expect is in the bed and what's wrong with them. Now, on page 185 and 186 of the textbook, there is a description of what the actual death process is like when you are what they call actively dying. The lady in the veranda with the tea wearing her nice leather shoes is elderly. She's frail. She's got problems. She's got the hospice diagnosis, but she doesn't look like she's on the actual verge of death right now. And if you need to know what the verge of, actually, why am I saying if? You need to know what the verge of death looks like, and it might not be what you think. But so on page 185, 186, there's a list. Now, I added which specific ones depend partly on the specific illness. What can happen is if you know what you're looking for, then you see a number after a while. So one of the things that's going to happen to you is you'll see some patients over and over again over the course of time. And it's actually kind of a privilege to have a relationship with somebody who's been coming to the hospital for a period of years or months, and then you kind of see whether they're doing better or worse, and then you remember it. But you know what? You can even see this in your own relatives when you see, as you see people age. The aging process is normal. But specific to when you get to the phase where the body functions are changing and the person is getting closer to having what we would say a natural death, there's just some kind of things where it's kind of typical what will happen. Now, a lot of times when we have somebody who is actually dying in the hospital and they decide they'll keep them there instead of sending them home to die, you have to teach the family or talk to the family what to expect, because they themselves, maybe they've never seen a person die or experienced being present during the death of a loved one, and there's teaching is very important, as we all know. And one of the things you kind of teach them of what to expect is, a lot of times the process of dying is one of just kind of gradually shutting down and fading out as you go along over the period of, shorter period of time. What happens is, it's not unusual, the person will be more short of breath or have particular breath sounds that are, and the text I think mentions this, it's called the death rattle, where it's like fluid fills up gradually. If you took the blood pressure every 2 hours during the process of dying of someone who was just doing this fading out thing, you'd see it would get lower and lower. The person slips in and out of consciousness, is not able to take fluids, urine production stops, everything kind of slows down. They may or may not have pain. We always try to make sure that we're assessing and asking carefully about pain so that they have enough pain medicine. I think that's the least you can do for a person. In terms of your own dealing with taking care of a person who's dying, it's much better. Somehow it's easier to, when you're thinking about it, rationalize that, yeah, they were 93 years old and they lived a full life. And when they finally died, we were able to make sure that there was not suffering or pain involved. I think that's a key thing. So one thing about end of life is that you want to see them, you want to make sure that you do have pain under control, and comfort measures. I mean, this whole section that you're supposed to be reading up is about pain, and the answer, the short version is, at the age of 93, in the final stages of life, you're not going to addict this lady by giving her a little bit more morphine. Now, I added this, and I'm surprised that these next two slides don't appear in the Pearson textbook or whatever. If we have to get down to it, a lot of what's important is we're going to be doing basic nursing care of comfort measures. Turn the person, make sure they're clean, make sure they've had mouth care and that they're comfortable, pain issues are dealt with, etc., etc. When a person is dying, they will have psychological things that they do go through, and one typical thing is Since the 1960s. Now, Elizabeth Kubler-Ross, I'm amazed that they don't mention this in the book. But since the 1960s, Elizabeth Kubler-Ross was a doctor who wrote this book called On Death and Dying, which was kind of like, let's not over-medicalize everything and treat every dying person like they're a experimental organism, because death is part of life. And what Elizabeth Kubler-Ross was saying, don't be afraid to actually talk with them about it if the time comes. And she pointed out that there are 5 different possible responses a person can be having. This doesn't mean every person has all 5 responses or that one is better than the other. And I think a big step is to recognize that if the person is having some of these responses, that's normal. Don't be afraid to deal with it. If they ask you about it, or they seem to want to talk, it's actually a privileged space to talk to another person about a major life change that they're having. And if you're ready for it mentally, I actually think it makes you a better person and gives you something better to be thinking about. And I'm not fixated on death all the time. You have to believe me. Now, since then, also there was another guy. And why did the doctors write these books and not the nurses? I think this guy stole everything from all the nurses. But Dr. Ira Byock, and up here is, I'm fixed it so that you click on this link, it will go to where you want to go. But Dr. Ira Byock said, basically what everyone, he was sort of like, what's a good death and what's a bad death? And he was defining a good death as if you have dealt with all your issues before you go, so that nobody is left wondering, oh, I wish I had, while they were still alive, I wish I had said this to them, or I would have liked to have heard blah, 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 or whatever before they died. And so, this is a way of framing the whole death process. And in case you haven't figured out, yes, we are all going to die, even me. I don't plan to do it today. But the thing here is, the conversations that people need to have, forgiving themselves for the small, piddly stuff that happened over the course of life that some people hold grudges for, asking forgiveness, thanking and telling the people that came to see you that you love them, all that stuff. We do that. When you can actually see that process happening, that's a way to derive some meaning, or that's a way to help people with grief afterwards, that I think is actually very important. And I put all that just as important as all the physical stuff, like making sure that they have pain control, or that they're not thirsty or whatever, or that they're help with hygiene issues. The rest of this is up there. Sometimes you don't know what to say, and that goes back to the mutual pretense from before. But if you do get to that phase, you'll be surprised. Sometimes people do want to talk about it. Now, going back to Mrs. Smith, she had an advanced directive at some point. And the whole idea of advanced directive is very important. It allows the person to choose what they want to have while they're making decisions in case they go unconscious. One of the questions is, would you do CPR on Mrs. Smith at the age of 93, knowing that she has what her history is and every other thing? Now, there might be some people who they say, I'm never going to die and I'm going to survive this. And I have to say, I've had my own relatives who had critically ill episodes at the age of 82, and that was 11 years ago now, but they're still alive. So it's kind of up to the choice of the individual, and that person has loved their life since then. There will be something on the chart which is called an advanced directive, and it will give information there. You need to know, you need to sort of always remind yourself to find the advanced directive and get the summary from the previous nurse as to what it was, and be aware of your patient's status. I think I told the story in class about somebody who did CPR on their first clinical day. Now, the story I told, that one was not, the patient who needed the CPR was not somebody that we chose. It was somebody who was on the ward that I had decided not to assign to a student because of various reasons. But, after that episode, basically every week, that particular group always checked advanced directives on every patient that was there. And you'll see there's a lot of effort put in there to making sure everyone on the team knows what the advanced directive says. Now, the book describes and defines palliative care on page 188. I'm not going to read that slide to you. Just like that, on page 188, it defines hospice care. And both palliative and hospice care are designations that people will have closer to the end of their life, and you need to know what that is. Bereavement, make sure you know what the vocabulary words are. Bereavement means grief after death, which is a whole nother subject, but part of hospice care is getting bereavement counseling. If a person does get hospice care, that they have to be officially diagnosed as having 6 months or less to live, and they have to have the kind of thing explained to them. A lot of people don't want to do hospice because they say, "Oh, if I sign up for hospice, that means I admit that I'm giving up." And I think it's very important to know, just because the person is getting hospice does not mean we're giving up or that they won't get what they need during the time remaining to them. And actually, in the hospice business, one of the things that would surprise you is sometimes you have a person who has been finally given a diagnosis and said, this is what you're probably going to die from. They find that to be like an experience of like having freedom and reevaluating their life and deciding they're going to live with the cancer. They're not spending every day dying with the cancer. Now, in the book, there's this whole thing about pediatrics and pediatric hospice. And I have to admit, one of the reasons I delayed making this voiceover PowerPoint was I just was totally irritated at the idea that the original PowerPoint had 10 slides on palliative and hospice care of pediatric cancer victims. Well, we aren't doing pediatrics. We don't know anything about oncology yet because that's coming up in a future semester right now. And it's like, oh my God, this is an overwhelming thing of the thing. So skip all references to pediatrics. There will be no questions in the exam on this subject. I did keep this slide that says collaboration. What happens is you have plenty of time to talk with others and have like a committee looking after whoever the patient is, and there will be other nurses around and doctors and families so that you can make sure you get the information that you need to know. And part of the thing is when you get to meeting the patient, if you learn anything new, you pass it along to everyone else who's also involved in that case. Now, this couple of these slides, here's the slide that says pharmacological therapy. One of the things is any person who is at end of life will get pain relief. That is something that we spend a lot of time messing around with, and to make sure that we get it right and the person can get through the day. Pain can be debilitating, and it's demoralizing to the person if they think they're not going to have pain control. But pain control is achievable. You're not going to addict the person to pain medicine during the 1 month prior to the time of their death. That's just a ridiculous idea. And the idea is, what can we do to provide the highest quality of life? And back to Mrs. Smith, I'm sure she was enjoying that cup of tea on the veranda right there. And probably the biggest thing of sitting on the veranda was, you notice she was all by herself. She wants to talk to you. She really does. And she's not just going to only talk about depressing stuff. Also here's another slide that says more things. And I added on advanced directives. If the person develops loss of consciousness, a lot of times they have to decide, well, if you're unable to swallow, do you want us to put a feeding tube and give you Ensure or something like that down the tube to keep you nourished? And that's part of it. Do they want to have that? Do they want to have CPR or not? And sometimes you'll say, well, I know I'm dying, but if you just do CPR for a minute and then you fix my pneumonia, maybe I'll live a bit longer, and that's what I want to do. I still want to keep going, even though I know that this one is, I want to go to the last possible minute. That's a choice the person makes. And you'll see that on the advanced directive as well. We're getting close to the end, and this might be the end. I can't remember, but in summary, okay, so anyway, wait a minute. The original last 10 slides or so dealt with assessment, diagnosis, planning, implementation, and evaluation, which ADPI is the whole nursing process. And it went into a lot of detail about all these things. But I looked at that and I said, well, okay, so we talks about the goals. We're going to spend a 2-hour class talking about goals. It talks about planning. We're going to spend a 2-hour class talking about planning, etc., etc. But guess what? We haven't done that yet. So basically, even though that was a great section in the original slides about nursing process, you're still very early in the education process, and we haven't even talked about that. So I have eliminated those slides. So now basically the goal at end of life is pain and symptom management, hygiene care, and basic nursing care. Making sure we do all the comfort things like turning them, skin care, that kind of thing. Using therapeutic communication, and especially allowing family or friends to visit, or having the person express whatever religious ideas they might possess, if that's important to them. I think we're close to the end. Let me see if we're not close to the end, I'll go to the next slide. But if it turns out this is the last slide, I want you to enjoy your Labor Day, and I want you to reread the 10 pages in Exemplar 3B with a renewed sense of purpose. Furthermore, I do want you to go and find the discussion section for this class and read the prompt on the discussion and reply to it. And I'll see you Tuesday.